So today I want to talk about a topic, and I'm going to tease it a little bit. Currently, there is a psychiatrist who was apparently, I've never seen that. We've never seen this guy, never seen him. It's more about the topic of conversation. He took some psych med, and I'm not sure which one, about 6 years ago, and now he has akathisia. And
Yeah,
his name is Jordan Peterson. We don't know him.
we don't know him. I've never seen Dr.
No,
Peterson.
nothing of it. His daughter has been
No
sharing.
disclosures.
Yeah, his daughter has Michaela has been sharing what's going on with him and saying
Yeah,
they're doing all this treatment. But the reason that we want to speak about it is chiropractic neurology is not well known yet. I mean, there are a few people, lucky people, as I'll say, that know about it, and we view our therapies from a different lens, and akathisia falls into that category. So this is all hypothetical. If somebody presented, we can talk about up and down around what we do, what we maybe wouldn't do, tests we would run, maybe that type of thing. So
100%.
I
Yeah.
personally haven't had anybody with akathisia in my office. So I'm gonna let you talk a little bit more about it.
I've seen it. Yeah, I've seen it. Well, and,
When
and the thing when you talk about our model and things like that too, the thing that's really interesting is, yeah, we're not necessarily in the medical mainstream for movement disorders, and akathisia is classified as a movement disorder
Mhm.
in the family with dystonia, Parkinson's, Huntington's, other choreiform disorders, et cetera,
Yeah.
correct? So what you're looking at is different hardware within the brain, which I know you're going to speak on as we go. But the thing that's really interesting when you talk about mainstreaming, Stanford and UPID, University of Pittsburgh Medical Center
Mhm.
use the neurointensive model that Dr. Carrick was the one who really started. And so Stanford's like, hey, yeah, we need to do this 3 times a day for 5 days as a minimum to build neuroplasticity. Stanford says it, and it's like, well, Dr. Carrick said that like
Yeah, leading the
several
pack, decades.
decades.
He is decades ahead. Yes, for sure. Yeah.
So it's like, yeah, our therapies aren't considered mainstream necessarily, or we're considered allied health providers. We're not, the classic functional neurology, but these clinics are doing functional neurology interventions,
But not to the detail
not to
and
the detail
understanding.
and not to the understanding of a Professor Carrick, or, in my opinion, of Carrick trained individuals, because
Mhm.
we've been doing this again longer than they have. And a
Yeah.
lot of times what you'll find is the sauce fits the individual in such a way due to Professor Carrick's observations, et cetera, et cetera.
Mhm.
And when it comes to movement disorders, I don't think there's anybody better in the world than him.
Yeah. I describe when I'm trying to work with someone, I describe nobody has the same exercises. Like, oh, you have this, we're going to shove you in the box and this is what you're going to do. I say you're a steak and we're going to decide the seasoning and how we're going to cook it.
Yeah,
You know, everyone's a little different and we're trying to find where yours is at. And
it's a
you
great
may go
analogy.
from like well done steaks to deciding that you actually like more medium well, meaning your body responds better to a medium well steak
Yeah.
versus. So that's kind of how I would
Taking
describe it.
Yeah, taking into account the autonomic factors, et cetera, et cetera. We've spoken on autonomic nervous system here and there, and
Mhm.
we'll continue to do so forever because it's out there and it's going to be out there forever. So
Do
with
you,
these,
I was
yeah,
going to say,
they're
let's start
hard.
with what it looks like, how it presents
Well,
typically,
and the
or
thing
possibilities.
typically, what akathisia is more a perceived feeling of shaking or vibration internally. And the thing that you will tend to see with some of these individuals is they do have some spontaneity of movement in the trunk or core or things like that as well.
Okay.
And things that we'll look at is we'll see dysfunction of movement of the eyes, square wave jerk movements, et
Hmm.
cetera, et cetera. We'll
Hmm.
see maybe even some fasciculations in other midline structures like the tongue. We'll see
Okay. Fasciculations
discoordination.
is like little
Tongue's
little
moving, yeah.
tremors for someone
And,
who
and and the
doesn't know.
thing about this too, okay, when we say this, the thing you don't want to do is make people go fasciculation in the tongue. If you're trained in neurology, you're going to say that's an ALS concomitant.
Hmm.
You see fasciculations in the tongue in a lot of places. It is a pathognomonic thing for ALS, but you see fasciculations in other places with ALS too. But
Hmm.
you're also going to see postural dysfunction as well
In
with these.
ALS or with akathisia.
With akathisia, you're going to see
Okay.
postural controls, dysfunction, things like that. You
Hmm.
may see some other spillover into other movement disorders, tremor, things like that as
Hmm.
well. But that's
Whereas,
the
and
the
I just want
traditional
to
ones.
back up because like Huntington's chorea. people they can get these big, huge movements, and these are more subtle
Yeah,
movements that we're
it's a
talking about.
subtle movement, or again, it's a perception of vibration, shaking, and things like that inside.
Mhm.
They just don't feel still in their skin.
Yep. Yeah. So
That's
when you,
traditionally what I have been taught akathisia is.
yeah, because if you were to Google it, the definition is similar to what you are saying, basically.
Um,
So
Chat
look at
JWM
you,
works as
look
well
at
as Chat
you,
GPT.
Google
Yeah.
Savant, John.
In fairness, I did teach the most recent iteration of the movement disorders, CNS, so
Okay.
I'm mildly up to date on the
Okay.
subject,
Good. We like
which is
that.
nice. Yeah.
Yeah. So they would present with these things. What kind of tests are you going to look at? You mentioned square wave jerk. So my office, I have VNG. We're seeing exactly what those eyes are doing. I
Yeah.
I was at a mixer last night with an attorney and other chiros, and this other chiro was like, my husband's done everything. He had a TBI and got a VNG, and I was like, who did the VNG?
Yeah.
And how do you look at it? Because a medical doctor is looking for, excuse me, major pathology, we're looking for tiny little functional aspects of it and how we can, because if there's a symptom and you see that, that's an issue. If there's no symptom and you see that, it's like, okay, well, hey, you don't have this symptom, but you have this going on. Do you want to try to do something about it? It's
Well,
how does it affect the human?
and the thing I think too, and let's say since I don't know, 2020 on your VNGs, have
Hmm.
you seen people with less significant findings feel worse
Oh,
than they did prior?
yes. Yep.
Yeah, that's out there, and again, you and I aren't the first people to
Mhm.
say this that
It could
I've
be the
mounted
pupil.
with.
I mean, we're talking like little things. And on a
Yeah,
typical medical read, and this is not to put down Western medicine
medical
at all.
neurology and everything
It's
like that.
just
Yeah.
what we've done.
Well, that's the
The
thing.
diff-
What you're looking at from a standard allopathic pathological lens is, can I pursue a target?
Mhm.
If I can pursue a target, the pathway's intact.
Mhm. You're
Therefore,
not gonna,
I'm
yeah,
going to move on to the next thing on my exam because I've got 35 patients in my lobby and I've got to find
yeah,
enough of a finding to prescribe however much Parkinson's medication or tardive dyskinesia medication or whatever it is that I can do so I can move on.
yeah.
We're looking, is the pursuit smooth or is it broken? How broken is it? Is it
What part
broken more in one direction than another? For
and what
example,
part of the brain does that relate to? Are there
and how
other
does it relate?
aspects like touch localization? Are
Yeah,
there other aspects that map in that similar part of the brain?
correct.
And if we fix those, does that give the body a better sense of where they are in space, therefore having a different motor output and even subcortical aspects? Do all of those
Absolutely.
things improve? So that's, I mean, to summarize kind of what we do.
In a nutshell, that's what we're looking at with whatever examination paradigm you're looking at.
Yes.
Again, can I make a saccade, which is a fast eye movement from one
Mm-hmm.
target to another?
Mm-hmm.
A medical doctor might say saccades are intact. Fine.
Yes.
And move on, right?
And they're
We're
not looking at,
looking,
is there multiple saccades? Do
yeah.
they overshoot? Do they undershoot?
Is it a
One
broken
way left.
saccade? Is it a slow saccade? Is it on target? Do they glide off the target afterwards? How well do they hold the target? Those are things we're looking at. So it's maybe you could say a more nuanced lens or things like that. Are we in the realm of the pathology isn't necessarily there, but the physiology isn't quite right?
I'm just going to take a break here for a moment. While this podcast is for educational purposes only, we would love a like, a share, shoot, even a dislike, a comment, so that the algorithms pick us up so that people can, maybe learn a piece of information for their health, or doctors like to listen to this in the background. It's possible. But if you don't mind like, sharing, subscribing, commenting, any of those things would be greatly appreciated. Thank you.
Which in movement disorders is very much what you really want is precise movement.
Yes. I explain to people, I'm like, when I do touch localization the most, where you touch and then they touch, and they're off by just this little much, I'm like, yeah, that's off. We are very precise. Our
Yep.
nervous system is not haphazard. It's not like, oh, I guess, well, that is my arm. No, it is very specific. And I harp on that every time I speak. It's like, no, we have a very specific nervous system.
Who do you
So
want to
that
be compared to?
little tiny bit in that pursuit being off can really affect a person's life.
Yeah, who do you want to be compared to? I want to be compared to Simone Biles when it comes to balance, not
Mm.
somebody who's a fall
Well, you're
risk.
gonna have to get shorter, so it makes it a little easier.
Yeah, yeah, she's a little lower to the
The
ground than me.
four
Not that
four
I'm
inches from that is a lot different than 4 inches from,
not that
way
I'm,
up. But
not that I'm
yeah, but
six
she's
five or
talented.
anything,
Don't get me wrong. Don't,
but
I'm
again,
not saying
I want to be
anything.
compared to somebody who's really high level performing, and I want to aspire to that.
Yeah.
And again, with movement disorders, which akathisia is,
Hmm.
and again, like you talk to like Krista Hubbard, who's one of our master's cohort, who's very
Diplomate. Yeah.
knowledgeable in the regard to movement disorders.
Yeah.
Her whole thought process is we need to be really, really precise in our performance of movement and our exercises. If I've got a movement disorder, or something of that nature, what's happening is my frontal lobe is not conducting through my basal ganglia to my motor system the way that it's supposed to.
Hmm.
And what's going to happen is if I'm not precise in my rehabilitation of that movement, I'm
Hmm.
going to make that discommunication between the cortex, the basal ganglia, and the motor system worse, correct?
Yeah. And more efficient at being worse.
You're going to continue to plasticize the
Yeah.
pathology. So that's where these things really matter. Whether you're doing a microsaccade with a dystonia patient, or you're doing, a finger to nose to finger with a Parkinsonian patient, or things like that, we want to hit the target. We want to hit the target smoothly. We want to hit the target precisely. And if
Hmm.
we're not looking at that in our diagnostics, because again, our model isn't necessarily driven that way, we're going to miss some of those details. And again, when you're prescribing medications, what are you doing? You're dumping chemistry into the system that is not necessarily specifically targeting just those loops in a specific fashion like we are in rehabilitation.
Hmm.
You may need some medication as well, and it's okay. We have Parkinson's patients that we treat that use medication all the time. The thought process is if I do this rehabilitation like we're talking about in a very specific fashion, what
Hmm.
I can maybe do, because by the time you get into Parkinson's, you've lost 80 to 90%
Recognize it. Yeah.
neurology that provides dopamine to the system. So you're dealing with not a whole lot of activity left. So what I want to do is lengthen and maximize the amount of time that that medication is effective for that patient by providing some precision in my rehabilitation plan. Because eventually, what you're going to see is dosages go up, dosages go up,
Yeah.
dosages go up.
There's
This med
there's
doesn't work. Go to this med, off and off you go.
there is no pill that fixes a functional problem, a functional neurological problem. There's no pill.
And when we say pill, we're talking medication that's prescribed
Coffee.
by somebody. We're talking, yes, a supplement that a
Hmm.
functional medicine provider might give you or something like that.
Yep.
That when you use any pharmacy, and again, supplements and herbal formulas and things like that are considered pharmacy as well, right?
Mhm. Yep.
It is something in my opinion, and I think anybody who really understands this kind of thing would agree, it is something to augment, supplement, and help to direct your rehabilitation, perhaps.
Hmm.
But you've got to do some kind of rehab. And a lot of medical doctors don't send movement disordered patients to physical therapy, occupational therapy, speech language pathology,
Hmm.
or something like that, who are people that are going to do some of these kind of things like we might do as well,
Yeah.
or us. They don't include us in the loop.
Hmm.
And what the ones that do notice, man, my outcomes with my patients are a lot better. Man, I don't have to do this. Or maybe they've got a deep brain stimulation implant, and the thing is, a lot of people, when they get this DBS, which is an implant that you put in the brain to make the basal ganglia kind of do its
It's like
communication with the
it's
cerebral
like you're
cortex
being
better.
more specific. You're getting on an area. So mitochondria, for example, creates energy, and it's like this electrical little thing is the mitochondria stimulating that nerve to work.
Yeah, yeah.
Hmm.
So we're putting an electrical stimulation into a neuron that otherwise isn't being driven because again, we've lost a bunch of the neurons. So we're driving the system, and what you'll see is decreased tremor rate, but you don't see things like their balance get better and things like that. So you go,
Hmm.
okay, they can move a little better, but they still don't have postural control, so you've got to rehabilitate them. And then a lot of times too, they'll get a DBS implanted, and the people that are responsible for kind of titrating that or adjusting the settings don't know when to change it. They maybe use a UPDRS system, but we come in and we do our diagnostics, and it's like I'm starting to see, a decline in saccade function, or I'm seeing a decline in pupillary controls or things like
Hmm.
that. So I'm like, go talk to your DBS person, adjust it. They love working with me because it's like, man, this we're getting a lot more out of this DBS than
Yeah.
we do with most of these other patients that we have.
It reminds me of same implant. different body part pacemakers.
Yeah.
And what I will see on sacudometry is that velocity of that of the eyes moving this way, that left cortex, it is just down
Yeah.
with the pacemakers.
And when you say that, what you're saying, and not to put words in your mouth,
Yeah.
is what you're saying is the integration of the left cerebral cortex in the autonomic regulating centers in the brainstem that connects to the heart
Hmm.
isn't as good as it should be, right?
Hmm. Yep, that
What you're
rhythm.
saying is if they see me, in addition to having their pacemaker, we can do some things to work with the neurological controls for heart rhythm.
And that's why we're specific about not doing certain electrical stimulations on the left side so as to not screw up that heart rhythm
Yeah.
pacemaker.
Yeah. There's a lot of people, I mentioned this to you on text earlier, they're doing vagal nerve stimulation to do vagal nerve stimulation because, it's the new biohacking thing. It's like,
Yeah, not everybody
everybody
should be doing it.
a few years ago, it's like, oh, hypoglycemia, and then it was methylation, and now vagus nerve stimulation is kind of the cool thing to do. And not always, right? Not always.
Yeah.
And that's where you go, somebody with akathisia, they may do that because again, it's like I'm nervous. I
You look
feel like I'm moving
hyper,
all
let's
the time.
calm you,
Yeah,
thinking,
because it's basically with movement disorders, you've got hyperkinetic movement disorders, which is too much movement, or
hmm
you've got hypokinetic movement disorders, which are not enough movement. And akathisia typically is kind of classified as a hyperkinetic movement disorder. So yes, can I calm my system down with this? Well, maybe it'll be really good, maybe it'll be really bad. If you're not having that system evaluated by your neurologist, Dr. Peterson, for example, or the patients that I've seen with it, don't know. Coin flip,
So,
maybe.
yeah, because Vegas could, let's talk through if you're stimulating that vagus nerve, you're stimulating parasympathetics. If there's a dysfunction in really the sympathetics would be where the dysfunction is, if it's
Well,
hyper.
the dysfunction in that model in both of these that we're working with is in the hardware between the brain and the brainstem, right?
Which is
which is
basal
which is
ganglia.
both well, the
Hmm.
basal ganglia has filtration pathways as well in there, so you see a lot of autonomic nervous system dysfunction with movement disorders. Again, I'm going to filter through the basal ganglia as I go down to my brainstem
Let's
to correct for movement.
give some detailed pathways is what I'm trying to pull out of you with that.
Oh, okay. So what I'm going to do is drive through my cerebral cortex into my neostriatum and then
Okay.
into
And
my
that's the
globus
basal ganglia.
pallidus. Yeah, so we're
Okay.
getting into the basal
And that,
ganglia.
so
Yeah,
the neostriatum, globus pallidus, these are all in the basal
this is
ganglia,
within the
which are
basal
right under
ganglia.
the cortex. They're kind of the
Yeah. Yeah,
no go part.
this is what we call extrapyramidal movement disorders or extrapyramidal syndromes, right? Because it's outside of the cortical spinal pathway.
Hmm.
So what you're seeing, we're driving into the globus pallidus, and then we're driving back into the thalamus, and then we're driving back up to the cortex to either
So
produce
it's
a
this
movement.
like loop. If
It's
I
a
could
loop.
draw.
That is what I just mapped out is what we call the direct pathway.
Hmm.
So you're causing an excitation of inhibition, of excitation, which you'll hear Professor Carrick say over and over. And,
And
and you
I
go,
have to stop and go, A
yeah.
plus B plus
So
C plus D. Yeah.
so the globus pallidus pars interna is the output for the basal ganglia. When it fires, you get movement. When it's inhibited, which is by the globus pallidus pars externa and the subthalamic nucleus, we get a lack of movement. And the thing that I don't like about the way that we were taught this in our undergraduate and in our chiropractic curriculum and the way it's taught in medical curriculum
Hmm.
is you go, I need to inhibit this pathway, I need to excite this pathway. It's on or it's off. And it's like, no, it's constantly being
It is fine
fine-tuned
tuned
at a
so that,
500 hertz refresh rate
yeah. So you're
so that
doing
I can do
this.
this.
Cerebellum can do it. Things coordinate this movement. And that's
Correct.
why when you see movement disorders, you get, you know,
You get not smooth movement. Yeah,
hmm
if I take this and I've got, say, a dysfunction and the ability to inhibit that pathway, what I'm going to do is I'm going to smack myself in the face with this, or I'm
hmm
going to shake and spill the water all over my lap,
yep,
or maybe I'm not even going to be able to get the darn thing picked up,
hmm
or I'm going to miss it when I go to pick it up, or something like that, or I'm going to knock it off of the cupboard, and I may shake with my entire body as I'm doing it because my brain isn't getting this fine nuanced dance. It's just like we talk about the sympathetic and the parasympathetic pathways. We want them both to work.
hmm
but I need my
And
frontal
coordination.
cortex to be the executor. The frontal cortex, we call it the CEO of the brain.
Hmm.
So the thing, if I come in and I just go ahead and stimulate my vagus nerve, what I'm going to do to get all these things to happen, I need blood flow. I need to dilate blood vessels. I need to constrict blood
which is
vessels.
more,
I
which
need
is
to pump
typically more sympathetic.
to a point,
The
right? To a
the
point.
Vegas comes in and helps control, like say we got it, you don't need so much here. Hmm.
But that's the thing. So say I get way too much dilation of a blood vessel in my brain. What is that? It's a
Hmm.
migraine, right? I'm going to get a constriction and a dilation and I get a migraine and I get all this other stuff and you don't want migraines all the time or worse, I really really chronically overstretch that tunica in the artery for a period of time. What happens? A hemorrhagic stroke,
Hmm.
right? All these kind of things. If I stress this tissue too much, but I want enough blood flow, but I want enough blood flow to go to other areas as well. I don't want to completely shut everything else
If I'm
down.
using this hand, I don't need blood flow to be as
Prominent in
distributed
the
to
other
this
hand.
hand if I'm not using it.
But you need it in the postural stabilizers on the opposite side so that you don't fall down when you grab the
Correct.
thing
Yeah.
either. So
Just
that's the
doing
thing.
this, the amount of vascular coordination and neurological coordination with a head turn is, we're driving. Can you
Yeah.
imagine if that just shuts down? It's like,
It's
it's
cool. I turn my head to the left and I shut half my blood flow down and I crash and it's totally fine, right?
yeah.
Yeah, but that's the thing. And then you talked about the cerebellum, which also speaks to these basal ganglionic structures,
Mhm.
dentato, rubro-thalamo-cortical loops,
So the
palatal,
outside of the
lutein.
cerebellum, I'm just going to break down a little bit. That cerebellum has four nucleus. The most lateral parts go more up, the more midline go down.
Yep.
So the dento is the
The
dentate
dentate
nucleus in the
nucleus. Yep.
lateral.
Yep.
Rubro
The red nucleus.
goes up to the opposite side. That's why that red nucleus is so big.
It's huge. Yeah.
Mhm.
It's huge. You look at that on dissection. Yeah. And then other pathways that we're looking at, corticoponomedullary, which loop in with this, which
Or
get
the head
into the
down.
locus ceruleus, which is
Mhm.
our autonomic control hub. Again, it's pretty big when you get
And
into the
locus coeruleus is a little more serotonin related, correct?
norepinephrine.
Is it norepinephrine?
Yeah. So that's
NTS is
your
what I'm thinking. Okay.
yeah. Well, and the
I missed
Raphe the
those two.
Raphe nuclei, yeah, the Raphe
Yeah.
nuclei are your serotonergic generators, but it's all in the same area, right? You got the locus coeruleus, and you've got the Raphe nuclei, and you've got the reticular nucleus, which it all
Is it
lives
net?
in
Yeah.
that brainstem, that ponomedullary and ponomesencephalic area, where
Hmm.
we've got a convergence between sympathetic and parasympathetic integration. All of this being received and again controlled by dorsolateral prefrontal cortex and other areas of cortex,
Hmm.
which again you go dentato, rubro, thalamo, cortico, striatal, palatal, Lewisian.
Hmm.
All these structures that we've mentioned are involved in this loop, and then corticoponomedullary, which controls the fuel delivery for that circuit. So
Hmm.
it's basically all happening at the same time.
How can
And
we jump in that loop? And where
yeah,
do we jump in that loop?
where do we jump in that loop? And that's where you see a lot of this deep brain stimulation come in, where they've tried to attach it directly to the globus pallidus. They've tried to attach it to the subthalamic nucleus. That's the popular one right now, I believe, is the
Mhm.
subthalamic nucleus.
Okay.
Some people went right into the thalamus. There's a lot of different DBS out there, and everybody's trying to figure out the best site
Yeah.
because, and there's only so much of that you can access surgically as well.
Yeah.
And the
I
cool
had a
thing about
patient,
us,
I
oh,
had a
go ahead.
patient get one and have it removed because it didn't do
Yeah.
anything. Hmm.
Sometimes they get an effect just from the lesion. They get the lesion effect where you just go in and you do that, and it's any kind of a change. They'll be calm for a little while. But that's the thing that's really cool is we've got ways that we've been taught as being character trained people how to leverage these areas very specifically with an eye movement or with a vestibular activation or
Hmm.
with different aspects of cerebellar activation, isometric contractions, complex movements, so on and so forth that can be very specific. And in akathisia, again, what you're seeing is unclean communication between the cerebral cortex, particularly the frontal lobe, and that basal ganglionic filtering device, which is responsible for making movements automatic over time. It's responsible for basically giving you the ability to do a lot of things really, really quickly and efficiently
Hmm.
when it works.
Yep.
It's kind of
So
a file storehouse for movement plans.
having done grand rounds with Carrick a few times and Jeremy Schmo's class. I'm on a lone island by myself out here. I don't have anybody with me, so it's
Same.
nice, obviously, to talk to you. But um, Jeremy, in his class that I took, is a visual one. He said how his patients are like, "Is this all you're going to do?" And it's something like a simple little head
Mhm.
turn, or just like he's like, "Yeah, we have to start there until you're
It may be.
stabilized to move
Yeah.
on." And this is what's missed in every other profession. I can't even call one out, but it's that detail of those little things. So if you have someone with a movement disorder and you go just past their fatigue rate or go just off, bam, their symptoms come flying back. So it's
Or
definitely a
worse.
detailed, yeah, it's
Yeah.
definitely a detailed um therapy, I guess is
And
what I'd
and
say.
and in these cases, again, I think what you just pointed out, less is more a lot of
Hmm.
times. It's very
Hmm.
simple. Everybody wants to, and I think sometimes we are prisoners of wanting to impress people with like really cool stuff every
Because
time
it
we
looks
can.
silly. The things I do, and I'm like, I know this doesn't look like anything, but it's helping your symptom by getting these parts of your brain. And yeah,
Yeah. And you do a couple of these with somebody who's maybe really compromised and they're like breathing heavy and things like that. And it's like, I know that doesn't feel like we did much today, but we did too much.
yeah,
It
yeah,
happens. It happens all the time. And you go, well, three yeses is too much. Well, if it is for you,
yeah.
it
That's where
is.
that
Yeah.
sauce is, that,
Yeah.
perfectly made steak for you.
Yeah.
Yeah.
Or we may not even do this, even though that's where their breakdown is, because it's too much. We might move in a horizontal plane. And the
Hmm.
cool thing about those vestibulocerebellar nuclei is they do communicate with each other. So it
Yeah.
may be a horizontal eye movement instead of a vertical eye movement. It may be a right brain therapy to bring your left brain back up to function, where you go, that doesn't make sense. Well, it doesn't have to make sense,
Yeah. It's
but it
cross-talking to
does. Yeah.
get back to that. Yeah.
Makes sense if you know the neurology. Yeah.
Yes. Pay attention to it.
Yeah. And
So,
and it's and pay attention to your patient. I mean, that's the thing. It's really interesting when you're dealing with somebody with akathisia, the
hmm.
feeling is very subjective.
Hmm.
So you're going to have to get some feedback. You're going to hope that they've got enough integrity to go, yeah, I do feel a little better. And you hope again, I feel better means the eyes are a little more still, the pupils are a little more directly responsive like they should be, as opposed to the opposite where you've really compromised them and they go, I feel better because
Yeah.
you just completely dug in the pathology and they're too compromised to know that they feel better. They're subjective. Of course, that's the thing that matters the most, right? Is the patient subjectively feeling better. That's what you
Hmm.
want. You want them to
Hmm.
check the list and say, here's your 5-star review, Dr. McLaren. I love you, but I want it to be a 5-star review because I actually did improve your neurology as opposed
Yeah.
to I compromise you so much you don't know
Yeah.
you're
We've
being
we've
skinny.
made this better. We put the Band-Aid over it, but
Yeah.
you're really still, your heart rate can't keep up, or
Yeah.
whatever it may
Or you're
be.
worse
I
than
don't
you
know.
were before you came to see me, but you can't
Yep.
perceive it anymore. It's
Yeah.
but
Your
yeah,
headache's gone, but you can't sit up. Hey, we're
yeah.
good.
Yeah, we fixed you. Good
We
job.
fixed you.
As long as you lay down for the rest of your life, you're gonna be fine.
Yeah. So with your akathisia patients that you've had in the past, do you remember
Yeah.
time frame that
Yeah.
it took for them to respond? What did you walk
the
us through
way
that?
the way movement disorders work, I will always tell people, hey, look, we're going to get again, by the time you probably are getting that patient in your office, they've maybe been
A
five,
million places.
600
Yes.
other places. Yeah, and they've maybe had a lot of different medical interventions, maybe some functional meta interventions, all these kind of things. So those pathways might be somewhat plasticized. So I always say we may get some really nice early results with you. And again, whether you're doing an intensive model or you're not, the thing to remember is you want to direct your care so they're doing something for that 3 times a day type of thing for at least 5 days to start to build plasticity. Um, again, with it, I've had some pretty good immediate results within the first week or two of treatment, but
Okay.
it's a long-term thing. You're
Yes.
definitely going to have to do some things with any movement disorder. They're going to have to do some kind of hygiene. We call this hygiene once
Mhm.
they're maybe, better enough to be functional, working, not miserable, etc. Great, but you're going to have to do some kind of hygiene probably for the rest of your life. I mean, I still do brain-based exercises every day, even though I feel pretty good now
Hmm. From
compared to
what?
where I was compared to where I was in 2022.
Hmm. Do you want to share what that was?
I absolutely would love to share with that in some future episode when we talk
Okay.
about
Okay.
dysautonomia. But
Okay.
yeah, so for those of you that don't know my story, I was hospitalized with COVID at the beginning of 2022. I found out I graduated our master's program while I was in the hospital. And I ended up
And you
with
were on a
completing,
ventilator.
I was actually on a ventilator. Yeah, I'm one of the few people that's out there who was on a ventilator and is now working full time.
Hmm. Yeah.
And
So,
I had a nice care team at Methodist Hospital here in Omaha. You know, no disclosures. I don't get any
mm,
kickbacks from Methodist to give them a plug, but Professor Carrick and his work is the reason I'm back to work.
yeah. And your muscles.
100% of the
You
credit
had a
goes to
lot
him.
of amino acid because you had a lot of muscle, so you that saved you for
It
sure.
was a great way to lose 45 pounds in 4 days.
Yeah. Yeah. Back to the akathisia. So Michaela talks about this medic. Do you know anything about the medicines that can
So,
lead to
so
akathisia?
most of your neuroleptics can give you that. Anything that you're taking for depression, anxiety, mood stabilization, those types of meds, which are
Hmm.
prescribed very commonly in the United States on a daily basis,
Hmm.
can predispose you to this.
Hmm. And then,
Seizure medications are also things that can predispose you to that. Those minimum, those kind of things. There are other things out there too, but those most commonly are we going to see in the neuropsych world that would give you that.
okay. Yeah, because it sounds like Michaela has gotten a bunch of people reaching out because they too had the same thing
Yeah.
happen. And, but that's why I'm like, oh, you're good on a med. Okay. Okay. I can,
And
I can't say you can or can't, but let's talk about what it does, what it can do,
outside of
because
our
you're not
scope of
getting the
practice.
proper consent is what I'm so.
And that's the thing. I think that that's part of the thing that's baked into the cake now. I mean, watch a pharmaceutical commercial on TV. You know, it's like,
And
yeah,
that's
you might
not even
end
the
up with,
whole insert. I mean,
yeah,
that's not
yeah.
even,
You're gonna
yeah.
end up with da 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 da
Mhm.
da 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 and anal leakage. And I'm like, I don't want
Yeah.
any of that.
Yeah.
And you know, and the thing they don't tell you is you may not get that to go away when you withdraw from the medication.
Yeah.
We see it all the time in the movement disorder community. We talk about tardive dyskinesia
Hmm.
in the class,
Even
and
from a birth control pill. You can get it
correct,
from birth control pill.
tardive dyskinesia,
Yeah.
and in this case, Jordan Peterson's akathisia is a form of tardive dyskinesia,
Hmm.
meaning it was caused by a medical treatment, a
Hmm.
medication for another condition.
And it sounds like he didn't have it for a minute. He stopped the medication, didn't have it for many years, and then it came back, is what it sounds like. Obviously, again, haven't talked to any of them, but
Sure.
based on what Michaela is describing in her videos. So,
Or if he had it, he was prescribed a med for something else and it exacerbated it. He
yeah.
was from the medication. It came, but again, now you have to ask, was he doing something in that time period where it wasn't there that was helping him, like maybe some autophagy, maybe he was doing more aerobic and anaerobic exercise, and maybe
Hmm.
he's backed off of that. Again, he's what, 5 years older or whatever it is, and it's come back.
Hmm.
So you've got the natural aging process that's kicking in as well. I'm not sure what he's doing
Yeah. I think
dietary
there was some
standpoint.
stress. I think her mom was sick, and so he was stressed out by that. Maybe that's what happened. He was stressed, and then he was put on a med to help deal with the stress of his wife being sick, and that happened also in the last 5 years. So anyway,
And
either.
stress is one of the things. Stress and trauma are
Hmm.
things that can absolutely trigger a movement disorder. You can take your genetic predispositions, you know,
Hmm.
like dystonia's got genetic markers, Parkinson's has genetic markers. Doesn't mean you're necessarily gonna get a movement disorder if you've got those gene markers, but you're
Yeah.
predisposed to it. Stress and trauma. Stress and trauma bring FND, functional neurological disorders out,
Hmm.
um, which is in the classification of movement disorders as well.
Hmm. Yep.
We were talking about that a little bit before we got on air today.
Hmm.
It's out there. And again, there are a lot of medications that don't specifically enough target these areas. They can help your treatment. Your treatment can help the meds. It's a synergy in a lot of cases where,
Yeah.
again, I think a lot of medical providers just don't know that they should loop somebody who's care trained or somebody like us or somebody who's working with brain rehabilitation in with that. They think the medication's all they need to do, and that's it.
Yeah. So to kind of tie this up, the reason we made this video, I don't know these people, but I live in carnivore land.
Yeah.
I love it.
Which is
And
another way to treat these things very
if
well.
if
Ketogenic and
there's a
carnivore
way to get
dieting.
this video to them, I'm going to try to to find someone. I don't feel like I would be the best person to see, even though I have these credentials. I don't see
Sure.
those regularly. You would be someone, but if they want help, I'm going to put a link in the bio. Both of our websites are going to be in there. They can
Cool.
go in, contact. I will do my best to guide them to someone, who can
Get
do
them
it.
to
And
the
if you're
Carrick
a person
Institute
who's not
website as
Jordan
well.
Peterson, If you're
Yeah.
not Jordan Peterson and you have this, I will still help guide you, to people
We can
who
find care trained
probably.
people in your area. Absolutely. And
So,
again, put the Carrick Institute in there as well. The Carrick Institute is very
yep.
helpful at finding people, find care trained people.
Yes. And not everyone's great at movement disorder. Not everyone wants to
True.
treat movement disorder.
True.
Um, I
They are
can't say that's
difficult
my strength,
cases.
but I can't say it's my strength. I'd be willing to take it on, but that's not, I need more experience, and you only get experience by starting. That,
But they're very difficult and frustrating cases because of
mhm.
that amount of specificity they require and the amount of things in people's personal lives that can make them more difficult as well. Because
Yeah.
the stress is still probably going to be there, or
Yeah.
there's going to be other stressors there, and you've just got to do things to harden the system
Hmm.
so that it
Or
doesn't
strengthen,
completely get set
strengthen.
off. Yeah,
Yeah.
yeah.
Okay.
Either way, yeah. However you want to put it, yeah.
Yeah.
I'll call that work hardening is a workman's comp term, and it's
Uh,
very much. I want the system to be more robust so that it can handle that.
yeah. All right. Anything else? We're gonna end it here.
I think that's really good for today. And I
Okay.
do hope it reaches
Yeah.
whoever needs help with this stuff. We're out here, all of us that are care trained are absolutely willing to help. And again, you may find somebody who isn't necessarily the biggest and best expert on it. They know how to find somebody that is and loop them
Mhm.
in. We
It
help each
is
other.
an it is the nerdiest bunch of people. I go to
Yeah.
conferences, different levels, I would say.
Yeah.
And I call them nerd conferences. When I talk to somebody else, I'm like, oh, it's a nerd conference. They're like, what? I'm like, neuro. They're
Yeah.
all nerds. People, we get so nerdy about the nervous system because it's fun. Not that people are suffering, but it's fun because it really, it's your life. So,
To steal from Cedric, NEURD. Yeah,
oh,
that's
that's good. Yeah,
Cedric's
yeah,
company,
that
Nerd
makes sense.
Solutions.
Yeah,
Yeah, yeah. To give Cedric an absolute plug and shout out as well. Yeah,
yeah,
Nerd Solutions, fabulous as well.
yeah.
Yeah,
All right. Well, we'll see you later.
always a pleasure.
All right. Bye.